Hello, everyone. My name is Jim Douketis, and it's my pleasure to welcome you to this evening's educational session. The faculty tonight encompass the following individuals, and these are myself and Drs. Lana Castellucci and Benjamin Bell, who are internists. As well, we have from the emergency department setting, Dr. Eddy Lang, and we have contributions from family practice setting from Drs. Alan Bell and Dr. Lauren Cameron, who contributed to the development and review of this program. And then finally, we'd like to welcome a non-Thrombosis Canada member, Dr. Dominik Mertz, who is an infectious disease specialist. So once again, the overall objective of this program is to share with you insights and updates about the management of patients with COVID-19. This is an important topic, as you all know, and regrettably, it's become very timely. So here, if we progress to the next slide, please, we can review the learning objectives specifically for this program. It's to gain knowledge about new developments and guidance on all aspects of management of patients with COVID-19. But very importantly, we want to hear your stories and we want to hear your questions, your insights on how you are managing your patients with COVID-19 in your practice, and also how we can work together as a medical team to support your patients, what resources are available, and placing the focus on them in terms of their journey through this disease. Next slide, please. There are a number of disclosures that we would like you to be aware of. First of all, the disclosures of our faculty are listed here. Next slide, please. And we also would like to disclose that we received for this educational program commercial support in the form of an unrestricted educational grant from Pfizer Hospital. We also want to make you aware of how we are mitigating potential bias in this presentation, and I'll give you a minute to review this statement on that. And we'd like to hear from you about this particular issue, whether in the chat line or more importantly, at the end of the presentation with your evaluations. And then the next slide, we'll talk a little bit over an overview about the agenda for this evening. So we're going to be walking through two patient stories. The first will involve a patient with newly diagnosed COVID-19 presenting to a family practice setting. And then that patient may progress and requires further assessment in an ER setting. And then shifting to a different situation, in this case, a patient who has COVID-19 but requires in-hospital management, and then progressing on to their post-hospitalization management. So overall, we're covering pretty well all facets of care involving patients with COVID, with the exception that we're not focusing on critically ill patients who require care in an ICU setting. The bulk of the discussion will be on the outpatient setting, but we also want to discuss the inpatient component of care. I want to reemphasize that this is interactive. Please send in your stories. Please send in your questions. I will be reviewing these through the chat line, and we will be discussing them as a panel so that you receive the perspectives and expertise from different specialties that is encompassed in our faculty. So welcome once again. And at this point, I will turn over the presentation to Dr. Alan Bell, family physician in Toronto, and Dr. Dominik Mertz, infectious disease specialist in Hamilton.
Well, thank you very much, Jim, for that introduction. As Jim pointed out, this is going to be a program that is focusing mainly on the outpatient management of patients with COVID-19. And I'm going to kick it off by giving you a very pragmatic view from guys like me, and I hope there's lots of you out there, primary care physicians down in the trenches, having to deal with these patients and the ever-changing guidance around what we need to do. Next slide. So I thought we'd start out with a case. This is an actual patient of mine. This is Charlie, not his real name. He is a 67-year-old auto mechanic who was complaining of fever, productive cough, headache, and myalgia of 3 days duration. He did not have shortness of breath. He denied it, no chest pain, and no gastrointestinal symptoms. He lives at home with his wife and one adult daughter. He was feeling unwell and went to a testing center where he got a PCR test one day prior to his presentation and informed me at the time on this telephone consultation that he was indeed positive. He has some significant comorbidity. He's hypertensive, he's hyperlipidemic, he's obese, BMI is around 35. He's an active smoker and has 20 pack years under his belt. And interestingly, part of this discussion, he also suffers from gout and has had many episodes in the past. His current medications include perindopril indapamide, rosuvastatin, and allopurinol. Next slide, please. So what are the considerations that I, as a family doc, go through my head when a patient like this presents? Well, I think that, we certainly have to consider, and the patient and their family and contacts are very interested in isolation strategy, and that needs to be understood and outlined for the patient. And as you'll see in a moment, that is a very fluid issue. Whether or not this patient requires any further investigations, how this patient should be monitored, and when that patient needs to be referred to hospital, and how this patient should be followed up. Now, also falling a little bit in our lap are treatment options, and the treatment options that we know have evidence in COVID-19 management are the anti-inflammatories. Certainly from an outpatient perspective, the inhaled corticosteroids are probably the most important, the most common that we often use. Oral steroids also need to be considered. Colchicine is a bit of a controversial topic, and I'm going to spend a little bit of time talking about that, as well as the IL-6 inhibitor, Tostalizumab. There are antivirals to consider, such as remdesivir. There are neutralizing antibodies to consider. Pretty much now limited to sotrovimab, and then the issue around anticoagulation, which I'm not going to get into, and is going to be focused on by subsequent presentations. Next slide, please. So let's start off with isolation strategy, and I'll start off by saying that this is indeed a very fluid topic, and in fact, in the rehearsal prior to this presentation, I had to change this slide because it was pointed out that guidance was changed in Toronto a couple of days ago. So I will also point out that the guidance that I am providing is going to vary from region to region, and what you are seeing here is guidance from Toronto Public Health, which may be quite different in the local jurisdiction that you are working in. So my practice, based on Toronto Public Health, is that all patients need to self-isolate for 10 days from symptom onset, or if they are asymptomatic from the date of testing. And self-isolation means just that. It means not just staying in the home, it also means trying not to spread it around your home. That means washing hands frequently, social distancing, preferably staying on a different floor of the home if that is possible. However, with the emergence of Omicron and Delta before that, the transmissibility of these viruses is so high that typically with household contacts, we are seeing virtually 100% transmission. What about asymptomatic contact? So our fellow was an auto mechanic. So what is the instructions for them? Well, individuals who are not fully vaccinated or had a recent COVID-19 infection, it's recommended that they get PCR testing. And that is a bit of an issue these days with the limited availability and long lineups to get PCR testing and to get resolution. But I think the important issue here is that not fully vaccinated individuals need to self-isolate 10 days from their last exposure. and that includes isolation within their own homes, the same as I outlined for the patient. Vaccinated or recent COVID-19 infection, recent meaning within the last 90 days. Again, PCR testing only if patients are symptomatic. There is currently no recommendation for these patients to self-isolate unless they are symptomatic, are immunocompromised, or are residents of a long-term care facility. They should, however, avoid any unnecessary visits, any unnecessary moving around, and they should clearly notify their employer for a local decision to be made about attending the workplace. Household contacts are a bit of a different story now. Prior to 3 days ago in Toronto, they were treated pretty much the same as vaccinated, as asymptomatic, as more casual contacts. Household contacts require now 10 days of self-isolation, regardless of vaccine or prior infection. I think that's an important point to take home. But again, you look at your own jurisdiction. They should also isolate within the home, as was discussed, and they should clearly inform their employers of the situation. And PCR testing is a good idea. If you're symptomatic, clearly need to be tested. If they're asymptomatic, again, it is an optional decision. Next slide, please. Okay, so what about monitoring? How do I monitor these patients? Well, first of all, I think it's extremely important to advise patients of red flag symptoms. And, the one that we typically focus on is shortness of breath. I think that's extremely important for patients to understand, but I hate that terminology. I don't think that patients understand it. We as physicians and healthcare professionals very quickly understand the term shortness of breath, but I definitely prefer to talk about trouble breathing. I wasn't short of breath, but I had a lot of trouble breathing. I've heard that one more than once. Sadly, within the last 6 months or so, I had a patient perish at home without any respiratory symptoms at all. This patient presented to the emergency room with gastrointestinal symptoms of vomiting and diarrhea, was discharged home with advice to come back if things got worse. He did not come back. He did not follow up. He suffered severe dehydration and died at home, sadly. So I think that it's important to remind patients that if they are exhibiting signs or symptoms of dehydration, including the inability to take fluids, syncopal or pre-syncopal episodes, and certainly reduced urine output should be something that they are aware of. I have the privilege of receiving a pile of home pulse oximeter devices. I've got about 3 dozen of them, and I do hand them out to patients who I consider to be at risk. Those who I don't hand them out to, I urge them to perhaps get their own pulse oximeter and to keep an eye on it. They're very, very simple to use. They can be taught in just a few minutes, and I advise them that any persistent drop in their baseline PO2 should trigger an ER visit. Even if it's, if it was running 98 and it's dropped to 96 or 95 and it's staying there for a day or two, certainly I think that is a reason that the patient should be visiting the emergency room. I typically don't require any investigations. Patients who require ongoing investigations due to their COVID illness, I think, are patients that should get a full workup in hospital. So I don't think there are any routine investigations that are required, but I do like to follow up with my patients. I advise them certainly to contact me or other healthcare if they have deterioration in their symptoms, but I will always book a 1-week follow-up to see just how they are doing. Next slide, please. So let's turn to the Ontario Science Table to discuss a little bit about therapeutic options in the patients that I see here. So these are mildly ill patients who do not require oxygen or fluid support. So first of all, antiviral therapy with remdesivir, anti-inflammatory therapy with tostalizumab or dexamethasone are not recommended for these patients. They do not provide benefit and in fact can provide harm. Inhaled budesonide, on the other hand, does have some evidence behind it. I'm going to quickly outline it. And 800 micrograms taken twice a day for 14 days may be considered in patients who have additional risk factors, patients who are over the age of 65 or over the age of 50 with immunosuppression, heart disease, hypertension, asthma, the usual list, and you can see them right here. It certainly is a therapy that you want to consider, and as I say, I'll go over a little bit of the evidence behind it. Therapies that are specifically recommended against and I think most of you are aware of this, are antibiotics such as erythromycin or azithromycin, hydroxychloroquine and chloroquine, despite what the former president of the United States had in mind. Similarly with ivermectin, as well as with the antivirals lopinavir or ritonavir. I will also point out that there's kind of an in-between category here where the science table did not feel that there was adequate evidence to recommend their use, but have not also specifically recommended against their use, and that includes colchicine, which I'm also going to be discussing in a little bit more detail. Interferon and vitamin D, still very much in the fringes. Next slide, please. So let's talk about colchicine. So altogether, there have been about 5 studies of colchicine versus standard of care in COVID patients, but many of these studies were done in sick inpatients, and actually a very wide heterogeneity of the severity of illness. And taken together, these studies have not demonstrated a benefit in progression, hospitalization, or death. But the big study was Col-Corona, which specifically looked at patients with mild outpatient disease. So there was almost 4,500 symptomatic patients. And importantly, at the time they did Col-Corona, it was actually Canadian leadership in this study. Because of lack of reagents for PCR testing, patients with or without positive PCRs were admitted to the trial. But they had to obviously have symptoms of COVID, and they were randomized to receive colchicine 0.5 milligrams twice a day for 3 days, and then 0.5 milligrams a day for the rest of the month for a further 27 days. And the primary efficacy endpoint was the composite of death or hospital admission for COVID-19. So this was a well-conducted RCT on a decent patient population, and a population that was very much reflective of what we see in primary care. Now, in the overall population, there was 2,200 patients randomized to colchicine or placebo, and although there was about a 1% reduction in the risk of the primary endpoint, that is hospitalization or death, it did not achieve statistical significance. These days, I don't think that represents the patients that we would consider for virtually any COVID therapy. So I think it's much more important to look at their pre-specified outcome of COVID positive population, where we saw over 2,000 patients randomized to colchicine or placebo. And in fact, we saw a 1.4% absolute risk reduction in number needed to treat of about 70 that was in fact statistically significant with a relative risk reduction of 25%. To me, that was, fairly strong data, but again, single study. Next slide, please. In terms of adverse events, the drug was quite well tolerated, and I think most of us in primary care use colchicine fairly frequently. I use it all the time in my gout patients, and what we see with the drug is a bit of diarrhea. And in this population, we saw about 14% of patients getting diarrhea compared to half that number in the placebo arm. This was not typically a serious adverse event, but I think what was important and a surprise that we saw in the safety data was this 0.5% risk of pulmonary embolism in the colchicine patients compared to 0.1% in the placebo. Again, it's a small number and it's hard to understand. And if you look carefully at the data, I think that there is strong reason to believe that this is probably not a real finding. But again, we see no evidence of deep venous thrombosis. In studies that have looked at, for example, biomarker changes, we see actually colchicine reduces D-dimer. We didn't see any evidence of thrombosis in the colchicine cardiovascular trials of over 10,000 patients for 2 years. And further, there's really no biological basis that I am aware of that is associated with a prothrombotic state in use of colchicine. Next slide, please. So inhaled steroids, 3 trials that I'm going to briefly talk about. The STOIC trial looked at a very small population, 167 adults with mild symptoms, randomized to inhaled budesonide 800 micrograms twice daily. the primary outcome was any urgent care or emergency room visit, which was reduced by budesonide from 15% in the placebo group to 3% in the budesonide arm, which is about an 88% relative risk reduction, pretty strong. But let's remember that this was a very small population, that it was non-blinded, and that many of the outcomes, many of the reasons that patients did end up seeking emergency care or urgent care were not COVID related. So based on that phase 2 study, the big phase 3 principal trial was conducted with 4,700 high-risk patients. These are the usual high-risk features that you can see in the asterisk at the bottom, who were in the community. And they compared, again, inhaled budesonide 800 micrograms twice a day for 14 days compared to standard of care. And the dual primary outcomes were time to recovery, which was in fact reduced by 3 days in the budesonide group. But, again, time to recovery was very subjective, self-reported outcome. And the second composite primary endpoint of hospitalization or death at 28 days was reduced, but did not achieve statistical significance. And it was close. And in fact, if you look at the numbers, there was about a 25% reduction and a 2% absolute risk reduction. However, not statistically significant. And finally, there was a study looking at ciclesinide, and again, a relatively small population, where we saw the opposite. Here, they were randomized to ciclesinide 320 micrograms twice a day, and we saw that there was no difference in the primary endpoint of time to resolution of symptoms, but there was in the secondary endpoint a very large 82% reduction in hospitalization for COVID-related illness. So taken in its entirety, there's data here to support the use of inhaled steroids. Powerful, strong data, not so much. Next slide, please. So let's get back to Charlie. So how did I manage Charlie? Well, first of all, I made sure that he and his family understood what the red flag symptoms for worsening COVID are, making sure they understand that this is a severe, life-threatening illness in a small but not insignificant portion of the population. He was instructed to self-isolate for 10 days with home precautions. At that time, his family was all vaccinated. I told them they didn't have to self-isolate, but now that changes with Omicron, which is changing everything these days. He was provided with a home pulse oximeter that he got to keep as a souvenir. He was treated with budesonide 800 micrograms inhaled twice daily. And, so I had a chat with Charlie because I've treated him so many times in the past with colchicine about whether or not he wanted to receive colchicine. Now, first of all, colchicine 0.5 milligrams is not available in Ontario, to my knowledge. So he got the standard dose of 0.6 milligrams for the same duration of twice a day for 3 days and once a day for the following 27 days, and he tolerated it very well. Next slide, please. So I'll move away from this now, and I'll put out a few what-if scenarios. What if, we have to consider the vaccination status of Charlie? Our patient was fully vaccinated. What about the unvaccinated patients or the patients who had prior COVID-19? Would management be different? What if the patient's got some other major comorbidities worse than Charlie? Full-blown type 2 diabetes, coronary artery disease, or extreme obesity? What if the patient is immunocompromised or immunosuppressed, for example, on cancer chemotherapy? So to address those more complex issues, I'll turn it over to our infectious disease expert, Dr. Dominik Mertz. Dominik?
Yeah, thanks, Alan. And I think these are all very important points that we have to consider nowadays, in particular once we start discussing the, well, I would say more recent developments that we now have available in terms of treatments. And Alan already mentioned some of them in his overview. So vaccine status will be relevant, or immunity if there was a recent infection, and then in particular the comorbidities. One caveat that I want to raise at this point of time is that the studies we are going to present here, or I'm going to present in the next few slides, are largely done in non-immune, non-vaccinated patients. So a population that thankfully is relatively rare nowadays, given our very significant uptake in terms of vaccines. On the other hand, Omicron makes things even more challenging. And again, none of those studies would have been done with Omicron. So take all of what I'm saying today in terms of those studies with a grain of salt. Take into consideration that the studies have predominantly been done in a non-immune population. Next slide. So the first option are monoclonal antibodies, and I'm showing you here one study representative for that entire sort of group of treatment options, which is Sotrovimab, which is the one that seems to continue to work against Omicron, while the one that we used in the past, first and foremost, Regencov, has lost its activity against Omicron, so no longer an option. So the one that we will be using moving forward will be Sotrovimab. This study here showed a 80% relative risk reduction in requiring hospital admission if the drug was administered within 7 days of onset of symptoms in patients that obviously didn't have yet moderate to severe disease, which would have required hospital admission. So really using the drug out in the community before people would require or would get anywhere near hospital admission. As you can see on this table as well, there were 0 deaths in the Sotrovimab group, 2 deaths in the placebo group. Relatively small study with 500 people recruited in each of the 2 arms. The issue with monoclonal antibodies, as Alan already touched upon, is that we have a relatively clogged testing system at this point of time, at least in Ontario, Quebec, I hear the same, and probably in other provinces, the same challenges will arise with increasing case numbers. So we need to find a way how to prioritize those patients, excuse me, those patients who would qualify for treatment. And I will come back to those criteria on the next slide. And we may have to consider rapid tests to recruit for treatment. It also requires IV treatment and an observation period. So you sort of need an actual infusion clinic or a very active program that would reach out and help elsewhere and provide the treatment. And I also mentioned at this point, there's some data also on post-exposure prophylaxis where it seems to work, but you would have a much, much higher number needed to treat to have a patient benefit from it. And we have limited supply, so we really should target the highest risk population with our antibody treatment. This is from the science table here. And as you can see here, a patient potentially qualifies if they are within 7 days of onset of symptoms and have at least 1 risk factor or are age 50 or older. If vaccinated or a recent infection, they wouldn't qualify for this treatment because they would already have their antibodies and there's no benefit as far as we know. Again, Omicron question mark, but that's the best of our knowledge at this point of time. So you would only qualify if you're immunocompromised, which is the right side here of this algorithm. And if you are immunocompromised, have those risk factors, then you would potentially, or the patient would potentially qualify. What's the definition of immunocompromised? It's relatively wide. So you're looking at active treatment for solid organ or hematologic malignancies, transplant recipients who are on immunosuppressive treatment, more than 20 milligrams prednisone equivalent for more than 2 weeks, any patients on biologic agents, and even long-term care facility residents are listed here in this document. Again, The guidance can look slightly different from jurisdiction to jurisdiction. This is the Ontario approach currently. Again, there may be changes, in particular in the light of Omicron, but just to give you an idea of what patient population you're typically looking at when considering antibody treatment. Now, on the next slide, we start discussing the antivirals, which are not here yet. So both that I will present today are not yet approved in Canada. Molnupiravir from Merck has been approved in the UK. They had those very interesting findings where the interim analysis suggested a very large effect size here, with a roughly 50% relative risk reduction and an absolute risk reduction of close to 7% in preventing hospital admissions. While in the final data set, this effect shrunk by almost 50%. To an absolute risk reduction of 3% or roughly 30% relative risk reduction. So still significant, but not as optimistic anymore as we've been based on the interim analysis. And the UK decided to proactively collect more data in real world on this drug to hopefully guide other jurisdictions with how they are going to use this specific drug. On the next slide, you see sort of the Pfizer equivalent Paxlovid here. And unfortunately, this is science by press release, so we don't have a peer-reviewed publication yet. So we sort of have to go with what Pfizer tells you at this point of time, which looks very promising, though. So they found a 88% relative risk reduction in hospital admissions if treated within 5 days of symptoms in high-risk patients. So again, similar to what Alan mentioned previously, the typical definition of high risk, typically more than 50 plus risk factors, or then depending on the study, you're looking at 70 plus, regardless of any additional risk factors. And then they also found a 70% relative risk reduction in their standard risk patient population, which is a second trial, interim analysis. This trial is still ongoing. What's also interesting to see is that they report a 10-fold decrease in viral load, which may result in a positive effect in terms of reducing the risk of transmission to others, in particular in the household setting, where, as previously mentioned, attack rates, in particular with Omicron, are pretty significant. The assumption for both antivirals at this point of time is that they will continue to work with Omicron, hopefully as well as they did in the original studies with Delta. But we have to yet to wait for them to become approved in Canada and be available for us. Next slide. Another drug that's available for more than 2 decades, to the best of my knowledge, but we are looking at an off-label use, obviously, here is fluvoxamine, or Luvox. It's a selective serotonin reuptake inhibitor, so a SSRI. And the mechanism how we understand this works is through its immunomodulatory effect, and the assumption is that what's been found for fluvoxamine probably applies to any other drug within this group of SSRIs, including fluoxetine, for example, which may be better known nowadays than fluvoxamine. This is a study that's been published more than a year ago, November 12, 2020, in JAMA. And this study, as you can see, was the first RCT on this topic, very small, roughly 80 patients in each of the 2 groups. They looked at deterioration as the primary outcome. They had 0 cases with deterioration in their treatment arm and 8.3% of the 72 in the placebo group. So quite promising results. And then a larger RCT, which you can see on the next slide here, has been conducted and been published in the Lancet Global Health very recently. They used 100 milligrams BID for 10 days, started within 7 days of symptom onset. So same timelines as you would use for the antibody treatments, which is doable as long as those people who would qualify, again, have sort of a priority access in a potentially clogged testing system. They found a relative risk reduction in hospital admission of 70%, so quite significant finding, particularly if you consider the relatively low risk of side effects and costs, low costs for fluvoxamine compared to any of the more modern treatments, such as the antibody treatment and the antivirals. So the price tag certainly a major benefit, plus the availability of the SSRIs to be used off-label against COVID or severe COVID cases. Now, the question is the patient population, right? Here in this RCT, a very small minority, I believe it was 5%, had immunity, were vaccinated. So the vast majority were unvaccinated. So it is to be determined how much this adds in vaccinated individuals. So we are probably again looking at those high-risk patients that are not vaccinated plus have additional risk factors, or are vaccinated but have other underlying high-risk conditions as immunocompromised status, maybe the very elderly or the significant comorbidities. One of the challenges with the SSRIs, as you probably know better than I as an ID physician, is the interactions. That's something that people need to have a look at. Next slide. So this is basically a summary from Alan and my first part of the presentation, again reminding for the outpatient setting with mild disease, remdesivir, dexamethasone, tostalizumab, not options to be considered. Remdesivir, however, there's some early data that looks promising that if you give it even earlier than we will currently do in mild disease, there may be some benefit even in preventing hospital admissions. But again, it comes with the challenges of requiring intravenous treatment. Plus, we would love to see more data before we would consider making that step. As mentioned, unproven in any setting to the best of our knowledge at this point, but may be used in primary care in some occasions of things like ivermectin, hydroxychloroquine, lopinavir, ritonavir, so Kaletra, and the vitamins, vitamin C, vitamin D, and also zinc. The latter two show some benefit if in general in respiratory infections, if there's a deficit, but in people who don't have a deficit with either vitamin D or zinc, it's less likely that there would be a benefit there. So I will hand over to Dr. Eddy Lang now, who will look into what's required or what can be used for people who present with more severe disease and require that higher level of care in an ED setting. Over to you, Eddy.
Thank you, Dr. Mertz. And a real pleasure to be part of this panel and to have the opportunity to give you the emergency department perspective on COVID care. Just want to highlight the human dimensions of this terrible pandemic. The WHO reports that as many as 180,000 healthcare providers around the world have succumbed to COVID. And I think it's really important that we remember that and acknowledge the sacrifice that continues to be made even now as we're in the fifth wave led by Omicron. So let's turn to the case on the next slide. You know, the big challenge we have in the emergency department is often to decide who needs to stay and who is safe to be discharged home. Sometimes it's black and white, but here's a case that's in the gray zone. So 67-year-old male, unvaccinated, as can occur in any province, including Alberta, where I am based. And his presentation was with very little past medical history, a normal body mass index, tells us that he attended a small gathering 5 days ago, and then 2 days ago decided to go get tested with a PCR and is presenting now with the emergency department with a positive result, a new sore throat, mild shortness of breath, really only on exertion, and a minimal cough. And what we always do in the emergency department is make decisions largely related to oxygen requirements. And when we're not sure, because we don't want patients, as Dr. Bell described, to go home and then have bad outcomes, we will do a stress test. We'll walk them in the emergency department, and if they desaturate significantly with that trial, that's often reason enough to bring them in hospital, at least for very close observation. Next slide. So there are a number of tools that have been recommended or suggested for risk stratifying this population of patients that are in the gray zone. And I believe the one that probably emerges with the most validity and reproducibility is known as the SOARS or SOARS score. And it's given that name because it's an acronym for saturation, obesity, age, respiratory rate, and stroke. And those 5 elements, if given a score that is rated based on age, will tell you if your gray zone patient who's obviously not too mild to go home, that should clearly go home or would clearly need admission, should have a second closer look. And anyone with a score of greater than 1 has a high enough risk of mortality that we will try to get that patient admitted to hospital, assuming that we can find a bed, to bring them in for observation. Next slide. But of course, the key issue is if we decide that either there is no bed and this patient will be going home, what can we do to reduce their likelihood of progressing? And you've heard a little bit about this from Dr. Mertz and Dr. Bell. I'm just going to reinforce some of it. And of course, we are fortunate to have a program, especially for our low-income and vulnerable patients, to provide them with O2 sat monitors, which are critically important. But what can we do in terms of pharmacologics in the emergency department to reduce that risk? Next slide. I guess one of the key messages I wanted to leave you with is that COVID has been unprecedented in terms of the production of research across the whole gamut of indications in terms of conditions, whether it be diagnosis, whether it be public health measures. It's just like drinking water from a fire hose. It's just coming at us nonstop. There's hundreds of publications probably coming out on a daily basis. How do we make sense of it all? How do we find out what is really endorsed by trustworthy guideline organizations? So my recommendation to you is to go to the recommendations map. It's a Canadian product developed out of McMaster University with CIHR funding. And just imagine this, they have a system of navigating all of the guidelines that are currently out there, and they will draw them into one central repository that's searchable so that you can see what the WHO, the CDC, the IDSA, Infectious Disease Society, are saying about a particular treatment or intervention. And they will evaluate that not only for the treatments that do work, but those that are not really considered ready for prime time. So let's see what would fit for our patient. Next slide. So just to highlight again, in this RecMap library, you have over 3,000 recommendations drawn from guidelines covering the gamut of patient populations, settings, context, whether you're interested in screening, diagnosis, prognosis, and always being updated with regular search strategies. It's sort of a living database of guideline recommendations. And on the next slide, you'll see that if you were to do a search for emergency department patients and not keeping them out of hospital, like we've seen before, Sotrovimab is one that bubbles to the surface. And not only do you see the text of the recommendation, but you'll see that it comes from the Infectious Disease Society of America. And what the RecMap does is it gives you an evaluation of the rigor of the guideline. That's with something called the Agree To score. It tells you if there was any information, whether the guideline was well developed and based on a solid systematic review and an evidence base, and not necessarily on one study alone that may not have been ready for prime time. And you see the recommendation here, although it looks very promising, there were some, there's issues around cost, there's issues around availability, there's issues around the number of studies that have been done, which are not unlimited. and it's a conditional or often known as a weak recommendation in favor. Next slide. And you've heard about this. This is the landmark paper in the New England looking at how sotrovimab has affected the mild to moderately ill outpatient COVID victim who is, by receiving the infusion, is demonstrating an 80% reduction in their likelihood of hospitalization, but very tricky to implement. How do you get to someone whose symptoms started within the past 7 days and get them to have an IV infusion? I'll tell you, emergency departments are not quite excited about receiving these patients, and certain setups are required. So for example, here in Alberta, what we do is patients actually will be offered the treatment at the same moment that they get their positive test result on their phone. And if they qualify, there's a special physician that intakes the information. They will be receiving a visit from an EMS team that is equipped to start an IV and administer the 1 hour sotrovimab infusion. And as was mentioned by Dr. Mertz, next slide. This is kind of the last one standing amongst the monoclonals. Incredibly fascinating. The immune escape created by the Omicron variant has essentially neutralized many of the monoclonals that looked so promising during Alpha and Delta to keep people out of hospital. But now, at least for the time being, the Omicron seems to be, based on these preprints that I pulled out of Google Scholar, be the only one that still seems to have good efficacy against Omicron. What else can we do in the emergency department? Next slide. Again, as was discussed previously, the REC map does endorse, although it's a weak recommendation, the use of inhaled budesonide, a medication we use commonly to treat asthma. And again, based on the STOIC and the principle, and in eligible patients, those over 50 years of age, and of course, especially those who might be at highest risk for hospitalization, the unvaccinated, or those with beginnings of findings on X-ray or significant cough and bronchospasm, we are giving budesonide to patients to keep them hopefully safe and out of the hospital. And one other resource I'm going to leave you with, next slide. You've been hearing a lot about the Ontario Science Table, but also what I would point out is British Columbia has also an excellent online resource for what are the most current, accepted, ready for primetime treatments, and also some information on those treatments that are kind of in that gray zone and do not have compelling evidence yet. And obviously too small to see here, but you can download this and keep it at handy. It's divided into critical, moderate, and mildly ill patients. Next slide. And here again, it's for the mild and moderately ill, it's this monoclonal and budesonide that are given the dark green thumbs up for should be used or are currently recommended as standard of care in patients who have COVID. Next slide. Along, of course, with the use of O2 sat monitors to make sure there's no, because things can change dramatically if patients are worsening, and this is happening regularly in Calgary emergency departments. Patients are going home on day 1, coming back on day 3, going home again often, and then only when they truly need supplemental oxygen do we keep them in the hospital. Last slide. I will turn things over now to Dr. Bell, because unfortunately, despite the sotrovimab and the budesonide, our patient returned with oxygen sats in the 80s and was, of course, admitted to hospital. Thank you.
So thanks for that, Eddie. That was a great presentation. Unfortunately, that X-ray is one that I'm all too familiar with, as I'm sure many of you are on this call as well. And we are seeing lots of COVID patients come in despite the best efforts of outpatient care. So, what do we do when they come to hospital with progressive COVID requiring oxygen? Next slide, please. So the pharmacologic standards of care for COVID-19 inpatients is variable. It depends on the severity of illness. It depends on where they're located in the hospital, and depends on what kind of organ support they are receiving. To an extent, it also depends on on some patient individual characteristics. For example, whether or not they are vaccinated and what their risk of bleeding is. But generally speaking, we can divide the standard of care for COVID-19 inpatients into anti-inflammatories, so dexamethasone and tostalizumab, or other IL-6 inhibitors, into antiviral medications for a select group of patients, remdesivir, anticoagulation for most patients at variable levels, and finally at therapies directed directly at the viron itself, recombinant antibodies. Next slide, please. So probably the best data that we have for hospitalized specific COVID-19 inpatients, and as far as preventing death, is for dexamethasone. This trial is the largest one, about 6,000 patients. This is the recovery trial. Were randomized to dexamethasone or usual care, and of course, usual care now would be definitely to receive dexamethasone. So this was done very early on in the pandemic, but only published earlier this year. And what was found was that amongst all comers, dexamethasone appeared to reduce the chance of death. And the absolute risk reduction was in the range of 3%. But there were some very important subgroups to look at here. If you weren't receiving oxygen, so the no oxygen received group here, you'll note that the odds ratio for death was above 1. And so dexamethasone is at least potentially associated with harm in outpatients with COVID-19, although the 95% confidence interval did cross the line of unity. But because of that, we absolutely do not give systemic steroids to patients with COVID-19 who are not on oxygen. The benefit of dexamethasone conversely seemed to increase with the severity of illness. So if you were on supplemental oxygen by nasal prongs, low flow oxygen, there was a benefit in terms of death. And if you were in the ICU receiving invasive mechanical ventilation or high flow oxygen therapy, so more than 15 liters per minute, then the benefit was even greater. So this really cemented dexamethasone as the standard of care for all hospitalized inpatients with COVID-19. Next slide, please. Other important outcomes was in the ICU inpatients, it reduced the duration of time on the ventilator. And of course, in a situation where we're thinking unbelievably, once again, about potentially the need for rationing ventilators, that's an extremely important outcome. In patients who are on the ward, there was evidence that dexamethasone reduced the escalation of care to even requiring a ventilator. As mentioned, there was no benefit for those on oxygen. In the overall population, the number needed to treat was only 35 to prevent 1 death, and that number goes down, of course, with the increasing severity of illness. And it's a cheap intervention. It's $6.60 if it's given orally, and $91 total if it's given by IV. And the dose is 6 milligrams once a day for 10 days or until discharge. And that's in PO or IV form. Next slide, please. Remdesivir. So there's been a lot of discussion about antiviral therapies, and of course, you know, the panacea is having a therapy that addresses the virus itself, prevent the virus from getting worse. And so remdesivir is a drug that's been around for a long time, and if I'm not mistaken, was originally developed for Ebola purposes, actually, I believe. Has been, of course, extensively looked at in the COVID-19 pandemic. This is a meta-analysis that was published along with the Solidarity trial again earlier this year, but much of the data was gathered, I believe, in 2020. And really this meta-analysis is grossly affected by 2 trials: the Solidarity trial, the first one up here, and the ACT-1 trial, the second trial. All the other trials have very, very wide confidence intervals, and I don't really think add much. But what's seen between Solidarity and Act 1 is that, like dexamethasone, with severity of illness, you have a different effect of the drug. But it's actually opposite to dexamethasone. So in individuals who are already severely ill, ventilated, or on high flow oxygen, we observe no benefit to dexamethasone. Remdesivir, excuse me. Remdesivir really only appears to be a value in individuals in the early stages of disease. So really when the virus is most active and most replicating in the body. Once the inflammatory reaction has really taken hold in a patient's lungs or other organs for that matter, the role of antiviral medication, at least with remdesivir, seems to diminish. And so typically remdesivir, because of this data, is utilized in individuals who are presenting relatively early in their illness, and not requiring high flow oxygen or mechanical ventilation. And in that subgroup of patients, there's a suggestion of a mortality reduction with a relative risk of death of 0.8 with a confidence interval of 0.63 to 1.01. So just crosses the line of unity, but most of us do use this medication for individuals on low flow oxygen at the beginning of their illness. Next slide, please. How does it work? Well, it's a nucleoside analog, and so the theory is that it inhibits viral replication. As mentioned, there's no benefit for those who are critically unwell. There's no statistical significant benefit regarding mortality or intubation amongst all comers. But again, in the lower risk group, there's a numerical improvement in mortality that just crosses the line of unity. It may reduce an overall time to recovery, but change in length of stay is debatable. It's not really associated with toxicity. Rarely there can be issues with elevations in liver enzymes, but I've never seen it, and it's very uncommon. The data is not as strong, with a number needed to treat of 143. It's only given by IV, and so we don't typically use it for outpatients. And the cost is high. It's around $3,100 for a 5-day course. Next slide, please. Tostalizumab is another anti-inflammatory medication. It's obviously not a steroid. It's a anti-IL-6 medication. And it has become, on the basis of this trial that was more recently published in New England Journal of Medicine, this was the original non-peer-reviewed version of the data, not significantly different compared to what was actually published. And so about 4,000 patients randomized to standard of care at the time, which really was corticosteroid, and almost all the patients in this trial received dexamethasone. And these patients were randomized either to tostalizumab or placebo. And tostalizumab in this group of patients was associated with a 4% absolute risk reduction, once again, in death. And so that cemented tostalizumab as one of the therapies we use. The patients enrolled in this trial were not all comers COVID positive. They had to have a CRP of more than 75. And they typically were quite unwell. So the vast majority of these patients were receiving a form of non-invasive or invasive mechanical ventilation. Next slide. So it's an anti-IL-6 antibody. As mentioned, the theory is that it prevents the cytokine storm associated with the worsening inflammatory reaction and progressive hypoxemia that we see in these patients. I showed you the largest study of around 4,000 patients that did show quite a significant reduction in death with an absolute risk reduction of 4%, leading to a number needed to treat of only 25 to prevent one person from dying. It's typically given in a fixed dose, actually, 400 milligrams times 1, although it was investigated 8 mg per kg on times 1, and the cost is $1,000. Next slide, please. So I don't think that Thrombosis Canada can talk about COVID-19 without at least mentioning venous thromboembolic disease. And so, of course, VTE prophylaxis is a cardinal treatment in individuals admitted to hospital generally, and of course with COVID-19. And the huge discussion around COVID-19 and VTE prophylaxis has really been the intensity of the dose. The reason why this has been such a large conversation is because COVID-19 is clearly a prothrombotic state. It's hard to estimate because we don't really know the full scope of the denominator, but people have estimated the rate of VTE with COVID-19 individuals who are outpatients is as high as 1 in 100, perhaps lower. On ward inpatients, around 4 to 5 per 100, 4 or 5%. And in ICU inpatients, as high as 10% of patients can end up with VTE. And that's, of course, despite prophylactic anticoagulation. And so these observed rates of venous thromboembolism in COVID-19 inpatients led to a lot of discussion around the intensity of anticoagulation to prevent venous thromboembolism in such inpatients. It has come up in outpatients as well, but I'm not going to mention that data. Next slide, please. So the majority of data has been looking at hospitalized COVID positive patients. And you can see there are more than 80 trials that have looked at this. There's no way I can possibly go through all of these trials with you tonight, but the largest trials really are the Inspiration trials, the Rapid trial, and the multi-platform trial that I'll mention briefly on the next slide, please. So what has been found in the majority of these trials of COVID-19 in patients, looking at the intensity of anticoagulation, typically a prophylactic dose, an intermediate dose, or a therapeutic dose of anticoagulation, all for the prevention of primary venous thromboembolism, has been that in COVID-19 in patients who are not on high flow oxygen and not in the ICU, so typically patients who are on low flow oxygen by nasal prongs, it's been found that those individuals seem to benefit from therapeutic doses of anticoagulation for prophylactic purposes. Whereas in individuals who are more unwell, so the individual who is in the ICU or receiving high flow oxygen, therapeutic anticoagulation has either been associated with harm or no benefit. And so ultimately what that means is the individual who is on the COVID-19 ward on low flow oxygen is prescribed therapeutic anticoagulation for prevention of venous thromboembolism. And when then they're in the ICU, they're typically prescribed a typically intermediate, or sometimes prophylactic dose of an anticoagulant for prevention of venous thromboembolism. Next slide, please. So a few what-if scenarios, and I'll try to go through this quickly, being cognizant of the time. So what is the initial standard of care? So that individual that we talked about in the case who has failed outpatient treatment, sadly, presents to the emergency department requiring 4 liters of oxygen. Excuse me. That individual is going to receive dexamethasone 6 milligrams IV or PO. They're going to receive remdesivir, assuming they are within the first 10 days of illness. They're going to receive therapeutic anticoagulation. And of course, they'll be admitted and the best supportive care will be given as well. If the next day they're on more oxygen, so they've gone from 4 to 6 liters, have gone from 4 liters to a 50% face mask, or they're on high flow oxygen, they're going to receive Tostalizumab 400 milligrams IV times 1. And if they are on high flow oxygen, or if they've been transferred to the ICU, then the dose of the anticoagulant will be reduced from therapeutic to an intermediate dose of an anticoagulant. And that's how I manage my COVID-19 inpatients. And with that, I'm going to pass it along to Dr. Castellucci.
Thanks so much for that, Ben. We'll go to the next slide, please. So I have the opportunity to transition our patient from inpatient to post-discharge. Next slide, please. And we'll elaborate a little bit more on our patient that was presenting to the emergency department twice. And after the second visit, he was admitted to hospital. So as a reminder, he's a 67-year-old gentleman, COVID positive and unvaccinated and relatively well, with his only comorbidity being hypertension. So he was admitted to hospital and has now improved and ready to go home. And as you're going through his documents and preparing your discharge orders, you're looking through his records to see what needs to be continued after discharge. Next slide, please. And I'll touch on each of the 5 components that Ben discussed during the hospitalization, and we'll start with dexamethasone. Next slide. So our patient was hypoxic, as we recall, and he did need dexamethasone. And as we learned, it's 6 milligrams for a maximum of 10 days or until hospital discharge. Next, please. So there's 2 different scenarios that could happen here. So the patient could be discharged and not require supplemental oxygen. And if that's the case, then he receives dexamethasone in hospital only. Next, please. And the other scenario, of course, is that at some stages in the pandemic, we were discharging patients on home oxygen. And that was really to try to free up beds for other patients to be admitted. And earlier in the pandemic, I was not typically sending patients home to complete a 10-day course of dexamethasone, but one could consider doing that, given that it is available in pill form. But again, there's no strong recommendation to do that, as if you are discharging a patient home, then presumably they are improving and may only need the oxygen for a few more days. The other thing that I think is important to keep in mind is that many patients with COVID pneumonia develop cryptogenic organizing pneumonia. And this is a radiographic diagnosis, and sometimes a bronch is done just to rule out other infectious etiologies. And if this diagnosis is made, then patients are typically treated with a tapering steroid, usually prednisone in oral form. And so if this happens, then some of your patients may end up going home on a prolonged taper of steroids, and that should be done in consultation with the respirologist, with the respirology team following them post-discharge as well. Next slide, please. So the other treatment that we learned about was remdesivir, and we know that it's an intravenous form given for 5 days total. If your patient is well enough and is discharged before the 5-day course is completed, then it's not given as an outpatient and they just have a truncated course of treatment. Next slide. Tostalizumab is given as a single intravenous dose in hospitalized patients and not used post-discharge. Next slide. And then anticoagulation. So as Ben mentioned, the standard of care for moderately ill patients needing low doses of oxygen is to receive therapeutic anticoagulation. And that's given for up to 14 days during the acute illness. At discharge, anticoagulation is stopped unless there's another reason to use therapeutic anticoagulation, such as being diagnosed with DVT or PE during hospital admission. The other thing I'll mention is that the 14 days is what was done in the multi-platform trials. And so if your patient ends up being in hospital beyond 2 weeks, we typically do a dose reduction to either intermediate or standard prophylactic dosing. Next slide, please. One of the interesting things that we are still learning about is whether or not patients remain at elevated risk of VTE post-hospital discharge. And there are a couple of studies that I'll mention here. The Active4C trial is still enrolling patients, and it's led mainly out of the United States. And this is a randomized study that is comparing apixaban 2.5 milligrams twice daily to placebo for 30 days in patients that were admitted with COVID-19 for at least 48 hours. There's currently about 1,000 patients that are enrolled, and it's an adaptive design, so up to 5,800 patients may be needed. They're looking at potentially expanding into other countries to try and accumulate this data on a faster basis. And then some of you may have heard about the Michelle trial, which was published in The Lancet last week. This is a Brazilian study that was done in 14 centers in Brazil. It's an open label study that compared prophylactic rivaroxaban 10 milligrams daily to no anticoagulation for 35 days in patients that were hospitalized for at least 72 hours. And about half of the patient population was admitted to the intensive care unit. 320 patients in total were randomized, 160 to each arm. And what all patients received during hospital admission was standard prophylactic doses of low molecular weight heparin or unfractionated heparin. And to determine patients who were at highest risk, they used the IMPROVE score, and patients had to have a score of 4 or more, or an IMPROVE score of 2 to 3 with an elevated D-dimer above 500 in order to participate. The interesting thing about this study is that it is the first study to have published data in this cohort of post-discharge patients. And they used a composite outcome, which included symptomatic VTE, asymptomatic VTE, and arterial events, as well as all-cause mortality. So a large grouping of different outcomes. And at day 35, all patients had bilateral leg ultrasounds and CT scan of the chest to look for PE. And what they showed was that in the patients that received rivaroxaban, 3% of them had the composite outcome compared to the group that had no anticoagulation, where 9% of them developed the composite outcome. When you look at the individual components of the composite, however, none of them are statistically significant. And so I think that's a really important thing that we need to consider, especially when at least half of the events were asymptomatic events that were detected. And screening ultrasounds and screening CT scans are not standard of care, and it's actually difficult to get access to those in many places. So I think until we have more information, we would reserve prescribing DVT prophylaxis to patients post-discharge unless they really have high-risk features, perhaps including history of VTE or something like that. Next slide, please. And then lastly, from the treatment in hospital, we talked about the monoclonal antibodies. And this is given as a dose either pre-hospitalization or for select patients that are admitted to hospital and not given post-discharge. Next slide, please. And so we'll wrap it up, and I'll hand it over to Jim as our moderator for this evening.
Thank you very much, Dr. Castellucci, and indeed, thank you to all the speakers for a real tour de force presentation dealing with an array of pretty well all clinical scenarios involving patients with COVID. So we have some opportunity now for some questions, and some have already come in. And I'd like to maybe begin with some questions that deal with access of medications. And maybe Dr. Mertz, I'll address this to you perhaps. What's your view on the access of, and if we can anticipate problems with accessing some of the medications we talked about? And secondly, the second question is your anticipation of when we will have the antivirals available for outpatient management, specifically Paxlovid and Laregrio, if you can comment on those two issues that have been brought up.
I think, as it has been mentioned throughout the presentation, I mean, one challenge with the antibody treatment, obviously, is access in terms of having dedicated clinics of people going out to offer the treatments. I also have long-term care facilities in mind where we could theoretically actively go out and, in an outbreak, provide the treatment for those highest risk individuals. But yeah, it's proven to be challenging, and as you all know, we are all relatively short-staffed trying to get everything done that needs to get done going through this entire pandemic. In terms of the antivirals, molnupiravir, I understand that Canada has purchased 500,000 doses and has an option for another 500,000 doses. While Health Canada approval is pending at this point of time, and the communication came out a few months ago that it's undergoing rolling review since the summer. So it's well possible that this treatment may become approved, or at least the decision will be made earlier rather than later. With Paxlovid, I don't really have a line of sight. I cannot remember having seen or heard anything in terms of how many doses may have been purchased and where we are at with Health Canada review. In terms of antibody treatments, just the other piece that's been discussed, that Sotrovimab is the only one standing at this point of time. And my understanding again is that the federal government has purchased additional doses. So hopefully there's at least some supply moving forward.
Thank you, Dominik. I guess the message is we have to really stay tuned and be aware of these changes and in regard to the availability of these medications. Just on the topic of availability, one of our callers asked about the oxygen sats, the portable O2 sats, and how widely they're available for our patients. So I'll just ask the panel, any thoughts about that? Is this something that it's very jurisdiction specific or clinical setting specific?
As I mentioned in the program, about 6 months ago or so, there was a COVID at home program from the Ministry of Health in Ontario that provided O2 sat monitors for primary care physicians. When I saw that, I jumped all over it, and like I say, I got a couple dozen into the office. But in anticipation of this tonight, I went back to that site to see what was going on, and it's done. So it's no longer available through that source. But as I think somebody mentioned, that you can buy these things relatively inexpensively at Shoppers Drug Marts, I think, in similar places.
And Eddy, if I can ask you from an ER perspective, is this something that your colleagues are being asked to distribute, or where do things stand from your side?
Yeah, well, the point about the ready availability, whether you order it online or go to the pharmacy, I think is quite important. We're fortunate that our respiratory therapists have an algorithm that they follow. Not anyone qualifies for a SAT monitor. Women who are pregnant are one of the groups that we definitely give SAT monitors to. And you also need to make sure patients are comfortable using them and know what to do when certain readings fall into a certain range. So they're given a card, red, yellow, green, as to how the readings should affect their behavior.
And I know a lot of the hospitals have COVID at home kind of treatment programs. And Lana or Ben, is this something that is kind of routinely available for patients who go home after COVID pneumonitis?
So at North York General Hospital, we have a remote monitoring program available. It can be used both via the emergency department or following discharge, and we provide patients with a pulse oximeter that we ask that they return. It comes back about half the time. And we have a nurse that calls them on a daily basis to find out how they're doing. And if they're not doing well, then they receive a physician assessment over the telephone to decide what the next steps are. And really the idea, I think, is to prevent people from going back to the emergency department unless it's necessary.
In Ottawa, where I am, we don't have a program that I'm aware of for post-discharge oxygen saturation monitoring. I think there was a local research program that we had going on earlier in the pandemic, but nothing currently that I'm aware of. And so we counsel our patients about different signs and symptoms to watch for and to return to emerge for assessment.
Yeah, and on that note, one of our audience members provided some information about the use of guides to help patients who are going home on other medications, whether it's anticoagulants or Tostalizumab, and I think this is a very important kind of transition process that I know that there are resources available. Certainly there are. We know these for anticoagulants. Does anyone know of any other kind of more resources for patients? Like we talked, Eddy and others talked about all these great resources about evidence, but from my perspective, the Ontario Science Table has a lot of information for patients about who have had COVID and what to expect when they're going home and so on. Any other sort of resources that we should be making our patients available or aware of? Well, I think in Eddy, you mentioned in BC as well, there is other groups that are putting together this information, but certainly the Ontario Science Table is very comprehensive in terms of looking at the evidence, but also providing information for patients. And then another question, the last question about availability, one of our audience members asked about the availability of outpatient infusion programs for Sotrovimab. Well, whether in this case it was in the GTA, but I think kind of more nationally, is this something that's been becoming standardized in your place in terms of outpatient clinics offering this kind of treatment? Yeah, I certainly at our place is not something that we're routinely doing, and I know that there are more and more kind of post-discharge outpatient internal medicine clinics that myself and many of us participate in, but I think this is something that we'd have to look at a bit more. I don't think there's anything that's been formalized, at least not in Ontario, that I'm aware of.
I was quite impressed by the concept actually when Eddy mentioned it earlier this evening, and I think it's something that we should take to our leaders to see if it's something that can be deployed here in Ontario and more widely across the country potentially.
Yeah, for sure. Thank you, Ben. We got another question, just moving to the inpatient setting. This question, we didn't. One area of therapeutic area we didn't talk about. It was the use of antibiotics. And one of our audience members asked, is there a role for complementary antibiotics, whether it's ceftriaxone and azithro, in the management of hospitalized COVID-19 patients? And from my perspective, for what it's worth, it's kind of fallen a little bit off. It was used quite a bit initially, but with the emergence of some of these other proven treatments, it's kind of fallen back. Lana and Ben, what's your perspective on the use of antibiotics in COVID-19 pneumonia patients?
Yeah, thanks, Jim. I think early on, like you, we were using it a fair bit because there was always concern about co-infection and wanting to ensure that we were treating bacterial pneumonia as well. I think as we've become more familiar with COVID pneumonia, we realize that there isn't often a super infection component to it. And so we typically don't use antibiotics concurrently and focus more on the treatments that we discussed.
Completely agree. I think the rate of bacterial pneumonia in patients with COVID is less than 10%, if I'm not mistaken, and so it's not standard of care up front. I typically reserve it for patients who are deteriorating on the ward, and in that situation, I look for VTE and look at the lung parenchyma with a CT scan to make further treatment decisions. And if there's consolidation, if consolidation is called rather than the typical viral pneumonia pattern, and the patient's deteriorating, then I might consider adding ceftriaxone to such a patient.
Yeah, and I would agree as well. So shifting back to a little bit of the thrombosis realm, we have a question from one of our audience members about thrombosis and vaccines. And I thought, oh my goodness, I thought we were done with that. And the question is there any risk of thrombosis with the mRNA vaccine? So this would be the Pfizer and the Moderna vaccines. Has there been any new evidence to suggest a signal in that regard? And again, anyone might want to step forward on that one.
Jim, I think I think more on a reassuring side of things, at ASH last week, it was just presented from a large U.S. Study that there is no signal associated with any of the vaccines used in the United States, including Johnson & Johnson, which of course is an adenovirus vector. But so I think that's a reassuring thing that looking at the large cohort study in the U.S., we're not seeing a signal for the mRNA vaccines.
Thank you. Well, we need any reassurance we can get. Alan, this is a question for you. One of the and I just wanted to get your comment. One of our audience members wanted us to make sure that when we're prescribing medications like colchicine or fluvoxamine, that we're clear that we're not doing this for treatment of gout or treatment of a mood disorder. And how do you kind of reconcile that with your patient, and how do you instruct them in terms of how they're receiving this medication and how you prescribe it?
I think that's a great question. They raise an important point. I'll start off by saying that I use medications off-label all the time, okay? And typically don't make much of a comment. However, when it comes to COVID-19 and the evolving evidence and the potential severity of the disease, I would always have that discussion regarding the level of evidence as well as the indication for the drug not existing. I wouldn't write it on the prescription, I think, as the participant asked, but I would definitely have the discussion and document it in the chart. In the case that I presented, giving colchicine, that came from having a discussion with the patient, mentioning colchicine, because the patient was familiar with the drug. I mean, I slosh the stuff around all the time, and so it was a bit of a no-brainer for him to put him on it. But I did make it very clear that it was off-label, and I think the same thing applies to budesonide. There's no indication for COVID severity, prevention of COVID severity worsening with budesonide, and I think it probably should be mentioned in this area. But honest, don't typically do it.
Well, I'm going to just finish with one last question, and that is from the audience involving patients who have been hospitalized with COVID. And I'm going to go back to our kind of thrombosis kind of wheelhouse. And the question is, that patient is going home. They're still not very mobilized. Are we going to continue anticoagulant therapy? Lana, what do you think about that patient and their anticoagulants that they were receiving during hospitalization, but they did not have any objectively confirmed thrombosis?
Yeah, thanks, Jim. I think right now, unless there are higher risk features, such as the patients had prior history of thrombosis, I would avoid giving DDT prophylaxis post-discharge. And keeping in mind that patients, when they go home, are typically better than patients who are going to rehab. Patients that go to rehab, I do advocate that they still get DDT prophylaxis because, of course, they're still gaining their mobility back. But I think once patients are ready for discharge home, they're sort of in a better state than those that require discharge or to a rehab facility.
May I ask a question to the thrombosis experts in the room? I'm wondering how, when patients are admitted, not necessarily the ICU, but ward patients who are indicated for antithrombotic therapy, how do you manage them? So the patient with atrial fibrillation or the patient requiring dual antiplatelet therapy following a recent ACS, is that seat of your pants medicine or what?
Yeah, so for patients already on anticoagulation for AFib or other reasons, they stay on their anticoagulant. You don't. There's nothing to suggest that switching them to low molecular weight heparin is the right thing to do, nor is it necessarily the wrong thing to do. Just knowing that low molecular weight heparin is not a treatment for AFib and stroke prevention long term. For patients on dual antiplatelets, they were excluded from the multi-platform trials, so you could be on a single antiplatelet. So if you strongly feel that your patient would benefit from anticoagulation, then you can consider dropping one of their antiplatelet agents and understanding that it's still going to take some time to metabolize out of the system and there may be elevated bleeding risk.
And I would agree. Time is our adversary, and I'm going to have to bring our discussion to a close. I anticipate sadly, that we will be having these presentations and these discussions for months to come. I also like to again acknowledge the unrestricted educational support from Pfizer hospitals for this presentation. I'd like to thank all of the speakers for their tremendous presentations and insights, especially those from a patient perspective. And last but not least, I'd like to thank you, the audience, for your participation on a dark winter evening. We hope that our brighter days ahead, of course, and I wish you all the best of the season. Thank you again very much for your participation this evening.